Okay, the last part of chapter 23 is cystic fibrosis. It's an exocrine gland dysfunction, so the glands that excrete things, and you end up with multi-system problems. This is the most common lethal genetic illness among Caucasian children in the U.S. Approximately 3% of U.S. Caucasian people are carriers of it. It's an autosomal recessive trait, which means both parents are carriers. 25% of their children will not have it, and not be carriers. 25% of them will have the disease, and 50% of their children will be carriers but not have the disease. That's that autosomal recessive. Here's a picture that shows the main systems that are involved. The basic defect is this exocrine gland dysfunction. In the lungs, what we see is bronchial obstruction, because what's secreted is thick, it can't be coughed out, and you end up with respiratory problems. In the intestine, in the newborn, the meconium's so thick they can't pass it. So this sometimes gets diagnosed at birth if they don't pass meconium. Also the pancreatic ducts, again you have that thick secretion, so it's too thick to move through, so it ends up doing damage in those ducts. You get pressure building up because it can't move through. You don't have the pancreatic enzymes that you need put into the intestines and the duodenum, so you end up with malabsorption. You also end up with pancreatic damage done, and part of that is at the bile ducts, and it gets fibrosed, so you end up with this biliary cirrhosis and portal hypertension. Okay, the basic problem is increased viscosity, thick mucus secretions, and then this just ends up plugging things up, mechanical obstruction. So instead of thin secretions, we have thick mucoprotein that accumulates. As it fills up, it dilates things, precipitates, so it turns into big hard clumps, coagulates, forms concretions inside the glands and the ducts. The respiratory tract and the pancreas are the two most affected. We have an increased electrolytes in the sweat, and that is the way we diagnose it. It's called a sweat chloride test. They basically put a little thing on the baby's skin and collect sweat, and then they look at how much sodium and chloride are in the sweat, and it'll be 2 to 5 times greater than in a child without cystic fibrosis. The respiratory manifestations. Well, this is present in almost all CF patients. You get respiratory or GI, and most will have both. Now, most will have this, but how severe does vary. What happens is you get stagnation of the mucus. It can't move. It's so thick. They don't have that normal ciliary action that moves it up and out. It's just too thick for the cilia to move it, too thick for coughing to do anything. So it makes the perfect medium for bacteria to get in there. So these kids are colonized with bacteria. They just have chronic bacterial infections in their lungs. This does a lot of damage to the lung tissue. So this is what I said, tenacious secretions. It's difficult for them to bring it up, and then it obstructs. And with that stuff in there, you're going to get decreased gas exchange. With that, you're going to be hypoxic because you can't really get the O2 in, because it's having to go through this thick mucus rather than just a thin little membrane at the alveoli. You're going to get hypercapnia because the CO2 can't move out of the bloodstream and into the alveoli because it's going through this thick mucus stuff. Hypercapnia when you have that high CO2, that is acidosis. Hopefully you remember that from your chemistries. That you get compression of the pulmonary vessels as you dilate things and fill it up with thick secretions. Now those little tiny capillaries, the pulmonary blood vessels, are being squeezed because inside the lung, in the bronchioles and the alveoli, it's enlarged because it's full of stuff. So that prevents the blood flow from coming very easily, which makes higher pressure in there. So you have pulmonary hypertension, can lead to cor pulmonale, respiratory failure, and death. Often these kids will die of respiratory complications. And they just have this chronic colonization of the lungs with bacteria. They never really get over that. So the other system is the GI system. Again, they have these thick secretions that block the ducts, so it just doesn't move out. So you get cystic dilation, same sort of thing. By dilating the ducts with all this thick, turns hard stuff, you prevent blood flow, and then you just get this degeneration and diffuse fibrosis, so hard, non-functioning places all over. And the big problem is this prevents our pancreatic enzymes from reaching the duodenum. We need the pancreatic enzymes for the absorption of fat. So they don't absorb the fat, they don't digest it, they don't absorb it, so it comes out in the stool, and they have really bizarre looking stools. They're slimy and look like they have fat. Just like, the fat you see in your chicken when you're cooking it, it's all over their stool. They also have problems with absorbing protein. They have those thick secretions all through the GI tract, blocking the normal absorption. The endocrine function of the pancreas, remember the pancreas does a lot of things. One of them is controlling insulin. Initially that works fine, but over time, as that pancreas gets fibrotic, we're going to slowly have diabetes mellitus occur. And biliary obstruction results in multilobular biliary cirrhosis. So we also have problems with the biliary ducts. And they also have impaired salivation. They just don't make saliva. It's thick like everything else that they secrete. So they have a pancreatic enzyme deficiency. They have progressive pulmonary obstructive disease and chronic infection. They have sweat gland dysfunction. That really doesn't cause them as much problem though. They have failure to thrive because they can't absorb nutrients. They'll have weight loss despite increased appetite, and then gradual respiratory deterioration. So they usually present with wheezing respirations, a dry, non-productive cough. There's secretions in there, but they can't get them up, so it's non-productive. And then generalized obstructive emphysema. If you look on the x-ray, they'll have patchy atelectasis, so it's not a single lobe is collapsed, just little collapsed areas all over. They'll probably look a little bit pale or cyanotic. Clubbing of the fingers and toes, that's where the tip widens out, and that's a sign of kind of long-term hypoxia. You've got to be hypoxic for 6 months or more before you develop any clubbing. And they'll have repeated bronchitis and pneumonia. As an infant, they might have meconium ileus, so they don't pass the meconium. They can also have obstruction, distal intestinal obstruction. They'll excrete undigested food in the stool. Remember, they have digestion and absorption problems. They'll have wasting tissues, these thin, doughy feeling muscles, and they're prone to prolapse of the rectum as well. This will delay puberty in females, can make males sterile. Parents will say that their children are salty. When they kiss them, they taste salty, which they have a lot of extra sodium in their sweat. They get dehydrated because they don't absorb normally. They get hyponatremic and hypochloremic because they're losing that, and get alkalotic along with that, and hypoalbuminemia, so low albumin in the blood. The test to diagnose it is the sweat chloride test, and our goal is to minimize pulmonary complications, help them to grow, and then assist in adapting to this. This is a chronic illness. They're not going to get over it. We do a lot of CPT, that's the chest percussion therapy or chest physiotherapy, where we're bang on the chest to try and loosen stuff up. Bronchodilator medications, teach them forced expiration. We use real aggressive treatments for any pulmonary infections. They can have home IV antibiotic therapy. Usually we admit kids once or even twice a year, give them IV antibiotics in the hospital, and real aggressive, the chest physiotherapy, and aerosolized medications including antibiotics. Some of the other problems that we need to be watching for: pneumothorax, coughing up blood, hemoptysis, nasal polyps. They're prone for that. They probably will need to be on steroids or NSAIDs, and they will eventually probably need a transplant if that's available, if they're eligible for it. Sometimes there's so much damage to other systems they're not. GI management, we want to give them enzymes. Every time they eat anything, they take enzymes first. We bring them in the food and we bring them in the enzymes, because otherwise they can't digest it, they can't absorb it. They have a high protein, high calorie diet. It can be as much as 150% of what somebody else would have. We're watching for intestinal obstructions. If they did have a rectal prolapse, that needs to get reduced, and we may need to supplement salt because they lose so much in their sweat and just in their secretions. Their estimated life expectancy in 2003 was 40 to 50 years. This is exceptional. This is so much better than it used to be. It still depends on severity, and some die considerably younger than that. If we can maximize their potential, if we can keep them well nourished and prevent or early treatment, early aggressive treatment of infections, and really do the they call it pulmonary toilet, really aggressive CPT pulmonary treatments. New research, they're looking into gene therapy, bilateral lung transplants, and some new pharmacologic agents for these kids. Family support, we need to support the emotional needs of the family as well as the child, because this child needs these treatments even when they're at home. We've taught the family to do them. They're having treatments several times a day. They're in and out of the hospital. Even when they're not doing badly, they'll admit them for a tune-up, they'll call it, and then if they do get sick, they often end up in there. And the parents might feel guilty. This is a genetically transmitted disease, so the parents were carriers. They may have not known it, but often you have guilt associated with that. And here's a picture of a little girl in her vest. It's pounding on her chest, and so as she's talking, you hear her voice doing this vibrato thing. Yeah.